Billy, I reached for my teeth, but I don't have to go for that. Really? Good, good. Doing a webcast with Yemen, a country that's very far away. Yeah, they're very friendly people. They appreciate it. So it makes it better. You know how it is when kids appreciate what you're doing. Yeah. Well, it's the same kind of thing, something I like. So, yeah, you betcha. Yeah, man, as long as the pipe's working, life is fine. I tell you, I love this cartridge, man. It, I used to cough like crazy, but this seems to give a better flow. You know what I mean? The cartridge. Can you see it? Yeah, no, I'm on Zoom. Let me get off Zoom here. Right. Yeah, that should be fine. You see it okay now? Hold on a minute. Video. What's that? Oh, yeah. Oh, fuck it, Billy, fuck it. I tell you, this always happens with when I use Facebook. I'm not used to using it. I'm just used to using the Zoom. But anyways, yeah, things are going good. Everything all right up there? Jump on it, Billy. Jump on it. All right. See you. See you later. Okay. Wow. You know how far it is, and wow. And you don't have to take it, right? You think, right, right. Yeah, they want people to say, yes, I'm ready. I'm ready to work. No, the Uber people want people that work, that like to work. Say, okay, Billy, we'll talk to you later. Bye-bye. Hey, Ahmed. Oh, how you doing, Ahmed? Are you in, Ahmed? Okay, let me, trying to get you in there, Ahmed. Promote the panelists, but I don't know what's going on. Can you hear me, Ahmed? You declined, okay. Declining a med. Well, come in. I'd like to chat a little bit with you, if I could. Okay, Med, if you're available. It's not private, but you know, I want to tell you some stuff. All right.
Hi, John, can you hear me?
Yes, I can hear you. Can you hear me?
Yeah.
Uh, yeah, basically, we really need new blood on the internet. I can see now being around for a while, there's people that comes in waves, and then those people leave residency and go to you know what I mean? It's a continuing flow, but we're not renewing it enough, I think. And that's why you come in. My idea, which I'm gonna talk to Salim about, is to have you kind of recruit new Walter Dandies and
Oh,
tell people how to do it and how to register
yeah,
and that thing. Because it's really a good organization. It's got a great name. I think we should try to roll with it. We need new blood.
yeah. Look, sir, now we have three categories regarding this area that you just talked about. First, we have dental clubs for medical students. Also, we have neurosurgery legos for residents, and you can see chapters, neurosurgeons chapter for consultant neurosurgeons. So these are the categories for having all the, I mean, the levels of neurosurgery people.
Yeah, you could provide a lot of content, and I appreciate the content you're supplying now. You
Mhm.
know, do it like Sabea, and you know, you're supplying good content.
Yeah.
So, and that can be multiplied.
No, okay. In the coming few days, Professor Salim, as he told me that he will nominate me to be an executive administrator in the society globally.
Great,
Uh,
great.
by this way, I'm gonna announce that as a society, then the society at all, we will announce for having neurosurgery legos for all the neurosurgery residents around the world, and also will announce for the neurosurgeons chapter for all neurosurgeons at all. I mean,
And you can include free webcasting with neurosurgical TV. No,
yeah,
and that's going to make a difference. But I want to try to get sponsors, you know, for the meetings, if you
yeah,
don't mind.
yeah,
Uh, but
absolutely.
I feel that we can because I think most good thinking neurosurgeons would realize the importance of new blood, new minds, getting to the new minds. I think a manufacturer would understand that. it's not outside the realm of advertising possibility. I mean, why not? I mean, you know,
Absolutely.
these are young neurosurgeons and they're going to be around. So,
Yeah, absolutely.
and other neurosurgeons would appreciate the fact that they're sponsoring
Mhm.
something like this. You know
Yeah,
what I
yeah,
mean?
yeah, yeah, absolutely.
We've done that ever since we started medicine. We studied drug companies, funded conferences, other
Yeah.
company like Stryker, they sponsored this and that. It's not different. We're just adapting it to the internet. The-
Yeah, absolutely, you are correct. So anyway, if you have an idea to get a sponsorship from an agency, just let me know and just tell me how to do that. I have no idea and I have no experience regarding this, but
Okay,
if you guess me anything, I'm gonna do it immediately.
okay. Now, one of the things that's important is to personalize it. I'm not going to send emails to all these companies and no, I want people like you in the field that know the reps that come to the hospital. You know what I mean? I don't know if you know them personally, but you know, may one know someone else that knows one or neurosurgeons that knows one. You know, that kind of personal touch. I don't
Yeah,
want to just get an address. It's no good. We got to have the personal contact. And
mhm.
that can be done because they even have to sell equipment in Yemen. I mean, they have to sell, you know, the Yemen needs equipment too. I mean, so, you know, they can advertise for Yemen. So, you know, it makes sense, I think. It just makes sense. So,
Yeah, yeah, absolutely. I mean, here in Yemen, all neurosurgeons buy, equipments for the operations, and I mean all of that equipments. I didn't know how do they get it, but in general, I think if we have sponsorship for anything, it will be helpful for neurosurgeons and also for us. But I don't know how.
I don't know how either, but it's worth a try. And
Hmm.
I think it's going to work because digitally advertising has gotten better because
Yeah,
you can basically scan it with your smartphone and you can go to a video that the advertiser puts on. I mean, it's more immersive for the advertiser, so they get to do more for their advertising. I mean, it's really a better value. Now, it's actually going to change advertising, I think. I think it's going to head towards the model I'm using. By and large, not many people are using it, but I feel it has a place, and I feel that it's going to catch on.
absolutely.
And adapting basically the same thing that's being done now, but to the computer. So, okay, we're waiting for a couple, 25 minutes. Okay, I gotta do some stuff. So,
Okay,
um,
now I have to promote on WhatsApp and Facebook now.
okay,
So I'm gonna mute.
okay, excuse me for a few minutes. No.
Hi, John, can you hear me?
Yeah.
I have prepared for the next webinar. Okay. I'm going to show you all the details after this webinar. The next webinar will be with Professor Louis Borba and Professor Muhammad Zailidi. I think you know both of them. Professor Borba is the president of World Federation of Physical Societies, and also Professor Muhammad is the president of the past president of the Turkish Neurosurgery Society.
Now, what are they volunteering for?
What?
What are they doing? Are they lecturing? Borba and those guys you mentioned?
Okay, I have just prepared for that webinar. I mean, it will be the next webinar, and it will be, inshallah, on the 20th of the June.
Okay, just let me know. Write an email. Okay, if you haven't already.
Okay, everything is ready. All the details will be shared to you after this webinar.
Okay.
Hi, John.
Hey, Arshan, man, you're everywhere.
I'm following you.
From India, well, from Mumbai, and then to the last webcast with Ike. in where he's up in where's
Istanbul.
he?
He's in Istanbul,
Istanbul. And
uh,
now you're back to Yemen.
Yemen. What time you are
Yemen.
starting? When are you starting?
Right now, a few minutes. Dr. Sabea just arrived here.
Because it is late night, 10:30 here in Mumbai.
Oh, okay.
Yeah.
Ahmed, you're a resident, correct?
Who?
Ahmed, are you a resident?
I'm gonna start.
Ahmed?
Yes. I'm gonna start the residency after a few months, inshallah.
Okay, so you're a resident then, right?
Not formal, but as I told you, I'm postgraduate, but I'm gonna start the residency after a few months, inshallah.
Okay, we'll start residency.
Inshallah.
Okay. Sean has come to 3 webcasts today. And
I attended one. I chaired one session in neuroendoscopy.
Yeah, I was surprised. Sam said to me, "You want to televise that?" I said, "Sure."
Yes,
Sure.
yeah, Sammy was there. Yeah, some good session.
He organized the whole thing, right?
Yeah, he's the president of neuroendoscopy there. Organizing is done by one of our hospitals where I am attached to that place. It's in the hospital itself.
So Sam, is he sticking to minimally invasive neurosurgery, his conferences, or is he doing all kinds of conferences?
All kind of he's everywhere. Yemen
Okay.
is going here, there, so many places.
Oh, okay.
And I think he's traveling tomorrow or day after tomorrow. He's not going to stay for a full conference. That's what he was telling me today.
Well, hello,
Oh, I
Dr.
can see.
Sabea, greetings.
Hello.
Hello.
Good evening.
Hello, Professor Saleh.
Hello.
How are you?
I'm all well. How are you?
I'm good. Good to see you.
Good to see you too.
Yeah.
Dr. Sabea, Harshad has come to 3 webcasts today.
Mhm. 3 in succession.
Yeah, one in India one in Istanbul with IPE. He's at that conference of Yazdigil. And then one we were doing from IPE in India. And the third one, minimally invasive from Mumbai.
Right.
He's busy.
Interesting.
Okay.
Professor Saleh, we don't do Jordan this thing rounds nowadays.
We do.
I don't see it. I'm not receiving any mails for that.
I'm sorry for
Otherwise,
that.
I was a very regular visitor in your.
I will make sure that you will receive it.
Yeah.
Well,
Yes,
if you put it on YouTube, I could televise it also if you want.
Yeah.
But anyway,
Hi, there's Professor. Can you hear me?
Hi. How are you?
I'm good. How are you? It's a very long time that no see.
I know. It's the war in the Middle East is making lots of disruptions.
Of course.
You know, Dr. Sabay, we're trying to get Ahmed to recruit new Walter Dandies because we need new blood. You know how it is. We need to constantly renew the youngsters.
New blood.
Yeah.
Yes, we need new blood. We need it. I can see that now that I've been around for like 8 years or so, and I'm sure you've seen it before too. Generations change. They change. Time does not stand still.
Absolutely right.
I see it with Zoom. The people that learn Zoom seem to have gone on to other things. Not everyone, but some. You can definitely tell a difference of people that are new to it. I don't think the new generation is adapting it as much because we had to because of the pandemic.
This is the generation gap, as always.
Yeah. Okay, we got a few minutes.
Professor Ibrahim, you are on a WFNS committee somewhere. I read your name.
Sorry, I did not hear that.
You are on a WFNS committee somewhere, right?
Yeah, I was in so many committees, but not recently now.
Also, WFNS, yeah.
As I said, the situation in the Middle East is really frustrating. We want peace to be in the area, and we
Okay,
are not achieving this.
okay.
So it is frustrating.
And the other speakers here, Ahmed?
He will join in a few minutes, but I think he has.
Okay. No, I gotta make a co-host here, so you can admit people if you see them. Okay, you know how to do that, Ahmed, right?
He is here. He is around. So
Okay, you can admit them there. You got the option now.
of course, he's. Dr. Adam, can you hear me?
You can hear
Sorry,
you.
I speak to me.
Hello, Dr. Adam, you are muted. I can't hear you.
Who are you trying to get a hold of, Ahmed?
Yes, salam
Oh, there you
alaikum.
go.
Hello.
Okay, welcome.
How are you all?
How you doing?
Great. How are you, Professor Ibrahim?
Fine, how are you?
Fine, thank you.
Good. Good to see you.
Nice to meet you.
Okay, I'll introduce you first, Ahmed, okay? And then you introduce Dr. Sabea and Dr. Alawadi, okay? I don't know who's going first or second. It was up to you guys, whatever. Okay, Ahmed?
Okay, of course.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, hold on. 3, 2. Good afternoon. This is Dr. John Bennett, televising from Neurosurgical TV, from Miami Beach, the home of Neurosurgical TV. We have another in the Yemen, Walter Dandy, Grand Rounds, and we have the distinct pleasure of having Ahmed Algamani. He's he's starting residency, and he's done a great job at organizing the Yemen neurosurgical community. Welcome, Ahmed.
Hi, dear John. Thank you for having this webinar with you and the Neurosurgical TV. It's my privilege and honor to welcome you all and also to welcome our guest. Firstly, I'm going to start with the Professor Ibrahim Speh. He is the past vice president of the World Federation of Neurosurgical Societies and also the past president of both Pan-Arab Neurosurgical Society and Jordanian Neurosurgery Society. So welcome, dear Professor.
Very much indeed.
You can go ahead, sir.
Mhm. Okay, we'll just hang on. He's done a lot of these. He's very experienced. Can you hear me, Dr. Sabea?
Yeah, there were some problems here in the transmission. We'll solve
Okay,
it. We'll
okay.
solve it.
Take your time. Okay, looks good.
Yeah, it was terrible to happen at this time of the day. Anyway, thank you very much for your invitation. It's always a pleasure to be with you. My name is Ibrahim Sbeh from Jordan, and my daughter, Dr. Asil Sbeh, should have been with me today. She's a neurosurgeon, a female neurosurgeon, 1 out of 500 female neurosurgeons around the world. I'm proud of that. And this is the Farah Medical Campus, Amman, Jordan, where I work. And this is my daughter Asil, spent some time with the professor in Germany. Craniophryngiomas in general have many classifications, but I'm going to start with you the accepted classification, the very common classifications. And you have to understand that the supracellular craniophryngiomas constitute the majority. It's about 85%, while the intracellular 5 to 10%, while third ventricular is 5%. Other classifications are intracellular, prechiasmatic, retrochiasmatic, and intraventricular. So no matter what the classification is the most important point is to understand the location and the relationship of this very unique tumor. So this is the hypothalamus, which is the main structure involved in craniophryngiomas. This thalamus, and this is the demarcation between the thalamus and the hypothalamus. Hypothalamus is made of anterior group of nuclei. It's only 5 grams that control our life. Every aspect of our life is affected by the hypothalamus, the 5 grams of brain tissue called the hypothalamus, made of anterior group, middle group, posterior group of nuclei. Each group of nuclei is medial and lateral, and they control the essence of our life. And hypothalamus is the essence of the management of the craniophryngiomas. So they control everything. They control pituitary, sympathetic, parasympathetic, food intake, fluid intake, metabolism, growth, sex production, temperature, circulation, sleep, wake-up cycle, attack, defense, attitude, memory, and so on. As I said, anterior, medial, and lateral, tuberal, medial, and lateral, and posterior, medial, and lateral. So this is it. This is a coronal view. This is the third ventricle, and this is the bit of the hypothalamus. Above it is the thalamus, of course, there, medial, intermediate, and lateral group of nuclei, like this also. And so the nuclei are scattered in these 5 grams of hypothalamus, which is the essence factor in the management of craniopharyngiomas. So the debate in craniopharyngiomas started and is still going on. Debate persists regarding the optimal treatment. Should we go for partial resection and radiotherapy, or should we go for radical resection? Comparing both, in my opinion, and I strongly believe in this, partial resection and radiotherapy has high recurrence. You need multiple procedures, and of course you add, in addition to the surgery, the complications of radiotherapy. For radical resection, there is less recurrence, less procedures, and no complication of radiotherapy. So upfront, I'm telling you, I am advocate of a radical resection, and I'll explain why. Many centers in the world are still dealing with the craniopharyngiomas in this lines of treatment. They puncture the cyst, they insert a Meyer reservoir, they do VP shunts, and they do minimal resection. And this is followed by radiation. This is, believe you me, that this is the general management of craniopharyngioma in most parts of the world. And this is wrong. Edlows, back in 2012, in his expert opinion, he showed a case of 4-year-old patient in 92. It was not his patient, but he knew about it. This patient received the VP shunt, right one, left one, then biopsy and aspiration of the craniopharyngioma, the revision of the VP shunt, then ended with the craniotomy for partial resection and radiotherapy. 97 had another craniotomy for recurrence. 99 he had recurrence in gamma knife. 2000 he had recurrence, he refused surgery, he died. This is the common story of craniopharyngoma, which we should all fight. This is wrong management. So what Edlow says, unfortunately, a case history like this is very common. Edlow, who's stationed in the Mayo Clinic, attempt at radical removal of tumor should be considered even for recurrent tumors. This is a man who's done most of his cases, most of his life, dealing with pituitaries and with craniopharyngiomas. Non-surgical options should be reserved as adjuvant therapy following surgical management. So surgical management for radical excision, according to Edlows, who is a world expert on this topic, is mandatory. So let's look at the radical excision in major surgical series. I'll start with Harold Hoffman. Back in 76, 21 out of 29 total removal with no recurrence. 1976, imagine. Harold Hoffman, again, 1977, showing these large tumors with the radical excision. Al-Mifti, back in 85, 20 cases of giant craniopharyngiomas with modern neuroradiology, microsurgical techniques, and endocrinology support. Majority of these lesions can be safely removed. Majority can be safely removed. Again, 2007, he described the Trozel approach for total removal of a giant retrochiasmatic craniopharyngiomas. Look at this large-sized tumors. There's no point in taking a specimen or just puncture the cyst and give radiotherapy. And he added, and that is Sam al-Mifti, a gliotic layer usually exists between tumor and functioning wall of the hypothalamus. So this old idea that you cannot separate the tumor from the hypothalamus should be looked at and criticized severely. 1990, Yazarjil, he described total removal of craniopharyngiomas in 144 patients. 1990, I'm talking about 35 years ago. We found that the best long-term control of these tumors can be achieved by complete removal of the tumor at the initial presentation. This is the giant of giants of neurosurgery, as Yazarjil. Carmel, back also in the 90s, we advocate radical resection as the optional treatment in all patients, especially in young children. Incomplete resection, and this is a very important statement, incomplete resection is a virtual guarantee of recurrence within 3 years. Carl Bush advocate aggressive removal. 2008, complete craniopharyngiomas resection with acceptable morbidity can be obtained in 80 to 90% of cases. Again, this is another world expert on these tumors. This is Falbush again, Erlangen, 2000. Radical excision of 94 cases with long-term good social functionality. So they try to make you believe that if you go for radical excision, you will destroy the patient life. It is the opposite. France, Venter there, in 2002, radical surgery gives better outcome of survival, full recovery, and quality of life for both adults and children. Another paper, 2005, from Zakoro, radical resection of craniopharyngioma. From USA, Tometa, 2005, total resection provided the best outcome. Again, from Japan, Minamida, he goes for, you can do multiple surgeries for excision. First surgery, recurrence, second surgery, excision, third surgery, excision, and no recurrence after that. So radical excision should be your main aim, not radiotherapy and chemotherapy and so on and so forth. Here is a paper from Germany, gross total resection 64 out of 65 cases. And most important that 21 were giants. Christian Sanrose from France, 2007. The best overall results is achieved with complete resection by experienced craniopharyngioma surgeon. Again, this is very important, experience. You don't give craniopharyngioma to juniors because they will not manage it well. You have to be an experienced neurosurgeon to teach and train other neurosurgeons how to do it in a good way. From China, I'm trying to bring you papers from all over the world. From Zhang, total tumor resection is feasible with the preservation of vital structures with low recurrence and low morbidity. From Slovakia, Stino, who is a major surgeon of this kind of tumors, final decision about the optimal extent of the tumor removal should be done during surgery. So you don't start from the beginning before you start the surgery that I'm going for radical excision or for partial resection and radiotherapy. Once you go in and see the anatomy, the adhesions, the relationship, then you make your decision. So the decision to go for radical excision is done during surgery. And the decision to go for partial resection should not be done before surgery. Yamada from Japan also, 2010, 70 patients, gross total resection 80%, near total 18%. From Musov in USA, 86 children in the hands of surgeons with experience in craniopharyngiomas. We believe that radical resection at presentation offers the best chance of disease control. What more do you need? What evidence you need more than this? Falbush again, 2012, 73 patients, a gross total 89%. No mortality. Pascal from Spain, 2013, described this very important that the tumors, they push the hypothalamus, both sides. So if you remove them, you should be able to preserve the function of the hypothalamus. And this paper also, is complete resection of the craniopharyngioma in adult feasible, considering both the oncologic and functional outcome? The answer is yes, yes, affirmatively. Complete removal of first surgery provides a chance for cure. From Japan, 2016, from Ohata, aggressive tumor resection should be the treatment policy. From Italy, Mortini, radical resection is associated with the best outcome. From Mayo Clinic, 2018, maximal safe resection via microsurgery or endoscopy provides very good tumor control. Okada from Japan, 81 patients, radical resection. So I'm putting these slides for somebody to, if you want to look at them, you can see the author and the year and the radical excision. Then comes the endoscopy. again, the endoscopy, Paul Gardner, the group Snyderman and all there, they go for radical excision. Endoscopy 2019. Gross total resection was in 86% in endoscopy surgery. 2009, Cavallo and the group, Bianca Snyderman, and Gardner, they describe this extended endoscopy approach for radical resection. Endonasal endoscopic operation for residual or recurrent, again, 2016. Reoperation should be offered to patients with recurrent craniopharyngiomas and may be preferable to radiation in patients in whom gross total or near total can be achieved. Again, surgery is the mainstay, it is the main goal, not radiation, not any other form of treatment. Fred Gentili, who was macroneurosurgeon, late Fred Gentili, we lost him last year. He's from Canada. He was a great friend of mine. He was a good macroneurosurgeon and a good endoscopic surgeon, and he went from macroneurosurgery to endoscopy. In both, he advocated radical excision. 2020 from Massa, 30 cases of craniopharyngiomas with radical excision. So I think I have given you a good amount of papers, not all of them, of course, I can't, time does not allow, to show you that the main neurosurgeons, the good neurosurgeons, they go for radical excision and without radiotherapy if they can. Other bad practice that I've seen over years is the upfront VP shunt. This is a crime against humanity. You just can't put a shunt and say that you have done the treatment for the patient. This is to say that you are a very false, bad surgeon. Look here, bilateral shunts. What are you doing here? What are you doing? This is practiced all over the world, especially in third world countries. Again, putting Umayya reservoir, Ayub Khan Umayya, who described this Umayya reservoir for chemotherapy initially. That is aim. They've used this Umayya reservoir to treat, for of course wrong reasons, to treat the craniopharyngiomas. Look at this Umayya reservoir. This is from Mayo Clinic 2018. Umayya reservoir is palliative. It should never be considered as a first-line treatment. All over the world, in bad neurosurgical hands, they put this Umayya reservoir. Still practiced today, yesterday, and tomorrow. Umayya reservoir is palliative, should never be considered as a first-line treatment. So my presentation is about radical excision of craniopharyngiomas, describing my personal series. 114 cases over from 90 to 2024, mostly children, 66 versus 48 adults. The classification by years. The youngest was 2 years, the oldest was 76 years. There is a protocol for all the cases, which we adhere to severely. Ophthalmological assessment, very extensive. Visual evoked potentials. And then these are the cases. Again, here the adults, here the children. Hydrocephalus was present more in children. Of course, you can get any kind of neurological deficits according to the size. Again, adults and children, the visual manifestation was more in kids. Endocrine is done for all cases. You can have partial hypo, total hypopit, more in adults. You can have DI and partial hypopit, or DI and total hypopit, again, more in adults. Hypogonadism, more in children. Hypoadrenalism, more in adults. Growth hormone, more in children. Hyperprolactinemia, more in adults. So all these are preoperative endocrinological assessment. Obesity was found more in children, which is, I will explain why. 12 in children, 2 in adults. And of course, we do psychological analysis for all patients, all neurosurgical patients that they need neurosurgical assessment. neurosurgical intervention, they should go for psychological analysis, pre-operative and post-operative. So the images in my series, CT scan is mandatory to show you the calcification. So various calcification in my series. The MRI will show you the extent of these lesions. Look at this, 114 cases, solid was majority, 50%, mixed solid and cystic, 52. So the majority are the difficult ones. The minor ones, the cystic ones, are the minority, 12 only. Now look at the size. More than 4 centimeters in diameter is the majority. So what I dealt with were the giant craniophryngiomas. You may ask, how come in Jordan, which is only 8 million population, you get this high number of cases? Mostly referred from all over the Arab world and neighboring countries. Look at these. Look at this size. Look at this extension of this craniopharyngioma, extending from here to the infratentorial to the occipital area. 7-year-old female patient. Sorry. So the size of these craniophryngiomas, which I dealt with, was so extensive that no radiotherapy can help. Only surgical excision would give them the best chance. These are all my cases, my collection. In coronal views, sagittal views, and so on. Explosive bombs, atomic bombs. Huge. So, in addition to the MRI, we do brain MRV and MRA to see the relationship of the lesions when we go for conventional angiography and venography if need be, CT angiography like in this case. The approaches I use in my series were subfrontal, terional, and interhemispheric. So I'm going to show you the steps of my series, the terional approach. So this is the right-sided terional approach. This is the optic nerve here, optic nerve there, and this is the tumor. So this is the tumor there, tumor there, and you can see the stalk here. The lamina terminalis approach, which I use extensively, and I published this lamina terminalis approach for third ventricular craniophryngiomas back in skull-base surgery in 2012. So this is the lamina terminalis, starting here from an anterior commissure to the top of the optic chiasm, this extent. And the lamina terminalis was described beautifully by Tomasello from Italy, 2002. The measurements, anterior posterior like this, 12 millimeter, and transversal like this, 825 millimeter. So it's a rhomboid. So this is the anatomy of it. It is a rhomboid area like this. Again, here anterior commissure, and here is the chiasm. So this is the lamina terminalis. Lamina terminalis is here. So you go in this, and you want to preserve the hypothalamus. Craniotomy like this. We cut the most anterior part of the sagittal sinus. And then we go deeper. We preserve the ophthalmic, olfactory tract. And you can see this picture of nerve, chiasm, and tract, olfactory nerve, olfactory nerve. These are from my series again. Left nerve, right nerve, the lamina terminalis is here. So you can see it here, bulging. I will show you different views of the lamina terminalis in different surgeries. It is here bulging in a very obvious way. Here you can see A1 on the right, A1 on the left, and the acron in between. And this is the lamina terminalis. nerve, chiasm, tract, lamina terminalis, and A1 here. Look at this bulge of the third nerve through the lamina terminalis. Here it is bulging through the lamina terminalis. Here you can see immediately that the chiasm is infiltrated. Another case of infiltrated chiasm. Again, here it has penetrated through the lamina terminalis and the tract. It's very apparent here. This is A1 on the left side, A1 on the right side. ACOM is penetrated like this. So opening of the lamina terminalis in various cases, you get the fluid out, and you have to make sure that this fluid does not go into the general subarachnoid space, otherwise you will get chemical meningitis. So doing this, you have done nothing. You just evacuated the small cystic part of the tumor. This is nothing. You have not achieved anything. In fact, you have done no favor for the patient. So you have to go for the tumor. You start dissection of the tumor from the chiasm, from the tract, from the third ventricular walls, from the floor of the third ventricle. Careful patient dissection. All this through the lamina terminalis. Here you can holding the tumor, and then you can separate it from the walls of the lateral ventricle, from the third ventricle. Even in this infiltrated chiasm, we could also able to separate the tumor from this infested chiasm. I'm not saying that you can achieve radical excision in every case. You have to stop when you have to stop. But don't decide this pre-operatively, say, I am going to do partial puncture of the cyst and send the patient to the therapy. This is, to me, a crime against humanity, which is practiced every day in many countries around the world. I'm sorry to say that, but this is a fact. So patient careful dissection. You can use the ultrasonic aspirator. In most cases, you need to, because some of these tumors are really very hard. Again, control of the ultrasonic is in your hands. So don't say it is hard, it's okay, you cannot remove it, you can. You can see the edge of the hypothalamus. You can see the mammillary bodies. You can see the midbrain. You can see the liquist and the midbrain. Now what to do if the stroke is not involved? If it is not involved, you have to preserve it. It's important. But you have to go for radical resection of the tumor. If you can preserve the stroke and remove the tumor completely, this is ideal. So I go for careful patient dissection to make sure that the stroke is separated from the tumor. So this is the stroke here. So the tumor here, if there is a plane of cleavage, you can actually separate them. And we are separating them here. This is the tumor, this is the stroke. Same here. And then you start seeing the basal artery, superior cerebral artery, and posterior cerebral arteries. So you preserve the stroke. That's the stroke coming from the brain going into the pituitary. This is basal artery and its branches. Now, this is a beautiful result. You have done something for the patients. You give them the best chance of survival, of good life. Now, what would you do if the stroke is tumorous? No hesitation. You have to remove it because you have to give the patient a good chance of recovery. So I don't hesitate in removal with the tumor of the infested stroke. Vascular structures, you preserve them, basilar, cerebellar, posterior cerebral artery, nerve chiasm tract, and this is deliquescent, tenor carotid on both sides. Now, to see this at the end of the surgery, this is very, very gratifying. I love to see this view at the end of surgery. So let's look at the results of this radical resection. Gross total resection was achieved in 36 in adults, 52 in children. Subtotal was, of course, less, but we go for subtotal if we find that we cannot. But that decision is made during surgery, after you have given every chance possible to remove the last bit of the tumor if you can, without damaging the patient. So all in all, total radical resection was done in 88 in 114. We had recurrence in 11. Some people say, well, we have done radical resection and you have recurrence. Of course, this is clinical angioma. It adheres to structures around it, and that's the cause of recurrence. But to go for radical excision, you give the patient his best chance. Mortality in the total resection is 1. Subtotal resection was 26 out of 114. Recurrence 16. Mortality in 1. Show you some results in others. 25-year-old male patient with this extensive tumor, from the foramen of one row here into the lateral ventricle down here into the posterior fossa. 25-year-old patient, and we have done radical excision. This patient, a 73, coming from another country, sent elsewhere. This was her presentation, extensive tumor. They went for endoscopic transsphenoidal, endoscopic removal, which was not a good idea to start with. However, in addition that it was not a good way to start with, she ended with aneurysm of the carotid, and the tumor was the same. So she was referred to us. Angiography showed the aneurysm. We neutralized the aneurysm intravascularly, endovascular management, and then we took her to theater and removed her tumor completely, and we sent her back to her country. This is post-operative. She remained well without recurrence. 30-year-old female patient from Arab country, Libya, who was, in a war state, a very poor medical services because of war. And this lady came with this giant of giants of pharyngiomas, almost losing her vision. We've removed the tumor completely, sent her back home without radiotherapy. She's been completely well without recurrence. 24-year-old male patient from another Arab country with this extensive tumor. We did radical excision of the tumor, and he remained well after about 5 years now from surgery. Another 45-year-old male patient from Libya, this country which was infested with war there. Again, radical excision, no radiotherapy. So let's look at the group. In adults, there was no new onset obesity. This is important. Obesity occurs in children. In adults, very few they have obesity postoperative. In my series, 0. new onset of obesity was 0. And this is the picture of the patients before many years after surgery. So no obesity in this adults group. Let's look at the children. Some of the cases are very giant of giants of craniopharyngiomas, like the atomic bomb of Hiroshima and Nagasaki, radical excision of the tumor, no radiotherapy. He's a child, don't want to damage him. 12-year-old female patient with this extensive craniopharyngioma, very extensive, cystic and solid parts. And again, look at the stability of this shunt. She was treated with a shunt. That's it. 12-year-old female patient, radical excision of the tumor. 5-year-old patient from Iraq with this extensive tumor. Radical excision, no radiotherapy. 13 years later, he was well. 3-year-old female patient in 2005, coming up with this extensive tumor. I did surgery in 2005, and this is her with radical excision of the tumor. In spite of this, 2007, she had recurrence. What should I do? Go for radical excision again. She grew up to a beautiful girl. 6 years later, she was doing very well. In children now, in comparison with adults, a new onset obesity occurred in 60%. But again, people say, don't do radical excision, otherwise you will have obesity. No, I would go for radical excision, and this obesity, if I'm doing surgery right, it will disappear in 3-4 years' time. And I'll show you. The operative, and then you can see the obesity, and then it disappears. Disappears from Sudan, disappears. Various patients, in 3-4 years, it will disappear completely. 11-year-old female patient. So there are complications of this surgery. This is major surgery, and to have some endocrine deficits is the rule, not the exception. Temporary obesity is also there. Temporary DI, permanent DI, and so on. Now let's look at the post-operative endocrine. If you feel that endocrine is going to improve by surgery or wrong, all of them, they will have worsening of endocrine, but later on it will improve. So partial hypopituitarism got worse in adults and in children. DI got worse in adults and in children. And then it will recover gradually. Visual improved in both. It got worse only in one patient, in an adult. Neurovascular hydrocephalus in 2 in adults. And of course, subdural hematoma, CSF leak, etc. It is there. So looking at my series in total of 114, quality of life was excellent in 94. This is very good. Mortality occurred in 2 cases, one in adult, one in pediatric group. And this is the adult one. This patient had surgery before he came to us. Look at the craniotomy site, and this is his tumor after the surgery. They have done nothing, they just punctured his chest. So I wanted to give him the best chance possible. I've done radical excision, but unfortunately he died on the 7th post-operative day because of the large size and adhesions. And this lady, 54-year-old with this giant of giants of craniopharyngiomas, I've done radical excision. She died on the 18th post-operative day because of complications. Histology is important. You have to do all the kinds of histological studies. Beta-catenin is important. This is a new paper about the beta-catenin gene mutation, published in Neuro-Oncology 2021. And this is a paper we've published. Dr. Abu Farsakh, the major histopathological expert here in Jordan, and myself about the differential expression of immunohistochemistry markers for epithelial squamous cell in adamantinoma craniofaryngiomas, and the promising horizons of targeted pharmacological treatment is still going on using the BRAF. This is a summary of what I'm going to say. I'm almost finished. Long, fruitful hours, dedication and perseverance, sacrifice of one's own time to give patients the best chance first time. The operation staff may go to sleep. You have to stay awake because this is the best chance of the patient. I'll give you this example of this patient. I treated him to the year 2000. I think he was about 2 years of age with this extensive craniofaryngiomas, very extensive. That was his post-operative. 2003, I gave him nothing, no chemotherapy, no radiotherapy, no shunt, nothing. 2005, 2007, 2009, 12, 13, 14, 17, no recurrence. He grew up to a beautiful young man that he is now. This is more than 24 years later. When I look at him, it gives me the pleasure of the world. It gives me the pleasure of the world. Look at this, no recurrence whatsoever. With this, I finish and give you my conclusions. That the results of radical excision is not superior. Some people would say this. Listen, radical excision is not superior to partial excision radiotherapy. This is not right. This is not correct. This is sending the wrong message to the young neurosurgeons who translate these statements to do minimum and send for radiotherapy. One should not go for radical excision no matter what, just to present good post-operative MRI, remembering that recurrence can still occur with radical excision. Using microsurgery or endoscopy, the aim should be radical excision to reduce the incidence of recurrence and avoid radiotherapy. This is important, decided intraoperatively and not preoperatively. So, state of mind before you start the surgery, say I'm going for biopsy or I'm going for radical excision. I'm against those people who go for biopsy. Total failure. I'm against the planned upfront limited resection and radiotherapy and other adjuvant therapies. Some people are worried about the hypothalamic function when one speaks of radical excision. Oh, don't do radical excision, you'll do hypothalamic function. This is a misconception. You can preserve the hypothalamus. You don't go just remove the tumor, no matter what. You want to preserve the hypothalamus. You want to excise it completely. Some people say, don't do it, otherwise you will have hypothalamic damage. What I say is, you are worried when they speak of partial excision with associated recurrence. This is going to cause hypothalamic damage. So it is their problem, not mine. With this, I finish and I say that knowledge has no limits. Thank you very much indeed.
Thank you, Professor, for this amazing lecture. Again, I would like just to thank you for accepting our invitation for this webinar, and I wish to have another webinars in the coming few weeks, inshallah. So again, also appreciate it for your professor.
Thank you. I'm open for any questions or comments.
Yeah, can you look in the chat room, Ahmed? I haven't seen any questions. Have you seen any? Or comments? If you want, you can just put in the chat any comment or question for Dr. Sabea. Probably should have announced it earlier. Okay. Okay. Ahmed, do you have any comments or questions?
I'm just
Right.
checking the chat for to know any question.
There's a question there from, can't read the name, about using of some
Oh, there's a
material.
couple questions, Tom.
Is radical versus subtotal excision total subjective to surgeon's abilities? Of course it is. Of course it is. It is part of your experience. It is part of your thoughts. It's part of your attitude towards this tumor. You want to take the tumor out completely, if you can, not no matter what. I want to go in, and my aim is to radically excise. But I will stop if there are problems, if there are adhesions. I showed you some cases where there's no way that you can completely excise the tumor. So you have to stop there. But I'm going in with the note in my mind, I'm going for radical excision. And I decide this as I'm working, not before. So the decision before, those group of people say, we are going for partial resection or puncture and then radiotherapy is totally wrong.
Mhm.
Question
Are there any
about
more-
the difference between terional and subfrontal approach. Subfrontal will not do for these giant tumors. You have to go for terional or for the lamina terminalis approach. These tumors which I showed you are very giant. They are really giants.
between
What advise you, junior neurosurgeon, to be able to achieve same results as you is to get yourself attached to a senior surgeon who's doing these kind of surgeries and learn from him or her. That's the only way. But to give these major tumors to juniors is a crime against humanity. And the role of bleomycin, well, people who treat these cases, they are inoperable, then you can give the bleomycin, but not upfront.
Do you endoscope in your surgery? Did you get that question?
Sorry, no, I did not
Yeah,
get
do
that.
you endoscope in your surgery?
In my surgeries, I'm a neurosurgeon. I don't use the endoscopy because if I need to, I would ask my colleagues to bring the endoscope in, but in most of the cases, I did not need to. I believe endoscopy is a great approach, but endoscopy is different from microneurosurgery. There are groups of giant endoscopy surgeons around the world. They do these tumors beautifully. They excise them completely, radically. So they believe in radical excision. Endoscopists believe in radical excision. Why? Because they see things different from seeing it from above. It's a different relationship with the chiasm, with the stalk, with the pituitary gland, and so on.
There's one comment by Al Kalesh, consensus for radiotherapy in children with subtotal resection.
Well, if you have to, you have to. But again, radiotherapy, whatever you do, is very detrimental for children, for their school age, for their learning, for their life in general. So try to avoid radiotherapy unless you have to. My message is very clear. I'm not against radiotherapy. I'm against using radiotherapy upfront. Biopsy, puncture of the cyst, and radiotherapy. This is a crime against humanity. But if I need to give radiotherapy because the tumor is completely removed or it is not being able to be removed completely, then this is the right thing to do.
Okay, very good. I think we can wrap it up. Thank you very much, Dr. Sabea.
Thank you.
We'll see you the
My
next
pleasure.
time.
Thank
And
you.
Ahmed, could you please introduce Dr. Alawadi?
Hi, thank you again, Dr. John and Dr. Sorry, Professor. It's my privilege and honor to welcome again Professor or Dr. Adnan Awadi. He is the head of the Neurosurgery Department at Thawra Modern General Hospital in Sana'a, Yemen, which is considered the reference and the largest hospital around Yemen. So, dear Doctor, you can go ahead.
Thank you, Dr. Ahmed.
Yeah. You want to put it on full screen? There you go. Perfect.
Okay.
Perfect.
First of all, I want to thank Professor Ibrahim Subeh and have a short comment about total radical excision of craniopharyngioma. It's depend about the experience of the surgeon, and as long as the experience of Dr. Ibrahim Subeh is more than 34 years for doing this kind of operation. It's long experience with skilled hands and good result for the total excision of this kind of lesion. In our country, we have this experience in doing these cases, and I also emphasize that this kind of craniopharyngioma should be only done in a specialized institute with the full equipped instrument and good staff with the collaboration of different departments, neuroanesthesia, neuroendocrine, and the neurosurgeon for this kind of operation. My presentation is most of it was explained by my Professor Ibrahim Subeh. I will talk about our experience in the neurosurgical department at Al Thawra Modern General Hospital. This is a short experience time for about more than 7 years in doing these cases, craniopharyngiomas, and only we will present the short case of this exam, for example, of these cases. First of all, we have no declaration for this kind. We give a small literature about craniopharyngioma historically. It was diagnosed first at 19,000 century. Regional corpuscle craniopharyngioma are a rare paracellular tumor that have a bimodal age distribution in both children and adults. It arises from the ectodermal remnant of radal pouch. Why are these craniopharyngiomas as challenging? Because of the location of this critical structure around this lesion and high recurrence rate about 15 to 50%. The management of craniopharyngioma is highly controversial, need for multimodal treatment and a high risk of complication, difficulty achieving a complete surgical resection. For epidemiological, it's about 0.13% in every 100,000 people. Their gender does not vary by gender or race. Regional distribution, some countries have higher risk for this kind of tumor. Survival rate is about 80% in 5-year survival rate. And subtypes, there are two types, adamantomatous craniopharyngioma and papillary type. The first one is in the shorted and the papillary type in adult. In low middle income countries, we see that some papers show that there is gender differences with the male predominance than female. In clinical manifestation, general manifestation including headache, nausea, vomiting, cranial nerve palsy, ataxia, and cognitive dysfunction. There is also presentation by hormonal disturbance, mostly growth hormone disturbance, followed by follicle-stimulating hormone and luteinizing hormone deficiency, adrenocorticotropic hormone deficiency, and thyroid-stimulating hormone deficiency. As we said before, this is all the two types, adamantomatous and papillary craniopharyngioma. This difference manifestation and between adamantomatous and papillary type of craniopharyngioma, with the incidence 90% is the adamantomatous type, and the papillary type for 10%. Age distribution is an adamantomatous type is in children and also can be occurred in the old age. The Beverly type exclusively in adult. 6, there is no gender differences. Classification of craniophryngiomas. We have so many classifications of craniophryngiomas. About 20 major typical classification of craniophryngiomas were identified based on surgical, pathological, and image finding. The most common anatomical structure of preference were the cilia and chiasmatic and third ventricle. The classification aimed to describe the major location of the craniophryngiomas such as intracellular, supracellular, intraventricular. Some classification consider the relationship of tumor with the pituitary stalk, hypothalamus, and infundibulum. Classification have evolved every time, reflecting advance in imaging and surgical technique. This is shot from the classification from the Atlas of Craniophryngiomas, which give some of the classification according to the Sergil and Hoffman and Sami. Last one is Signato QI, which was based on the embryological organizing site based on the surrounding membranous structure. For a differential diagnosis of craniophryngiomas in CT or MRI, the Rath cyst and dermoid cyst, epidermoid cyst, supracellular aneurysm, germinoma, hamartoma, and pituitary adenoma, and alarachnoid cyst. The three components of craniophryngiomas adhesion, which is the anatomical and morphological pattern and the adhesion strength, or anatomical structure involved, which are cilia and stalk, infundibulum, and cerebella and third ventricular wall, or the global cilia to the third ventricular wall. Morphological pattern of attachment is the pedicle or chisel, cap-like, or ring attachment is the green one, or bowel-like, or circumferential attachment. The adhesion strength is the loose adhesion to the surrounding tissue or tight to the pituitary stalk or the surrounding tissue, or there is a fusion or replacement for the surrounding walls. Also, it's being classified to mild, moderate, and serious and severe critical adhesion. The optic chiasm is normal here in the adhesion for the normal chiasm, compressed lesion, or is a stretch. For the approaches for the craniophryngiomas, tournial, orbitozygomatic, and interhemispheric, transcallosal, transphenoidal, bifrontal, basal interhemispheric, or subfrontal, translaminar terminalis. For our experience in our institute, we are depending mostly on tournial approach for most of the cases, which have been done in TMGH hospital. This is the classification of craniophryngiomas and surgical approaches for the cellular. It's dependent on endoscopic nasal approaches for the supracellular and interventricular and lateral extension of the tumor or intraventricular. Its tournial approach can be dealt with most of these cases. For the diagnosis and management algorithm for this kind of craniophryngiomas, we done for this charismatic to do management protocol, how to deal with these cases. For different treatment, there is a paper. We didn't use it here in our institute, like intracavitary radioisotope or intracavitary chemotherapy, beliomycin, or interferon therapy. For radiotherapy, as Dr. Brian Subaih, also we didn't recommend it for radiotherapy here, but unfortunately, as the experience of our surgeon is to do radical excision is not to do so much experience as Dr. Ibrahim Subaih experience. So we are trying to do maximum or total excision for all cases as possible as we can. Then if there is strong adhesion to the surrounding tissue or there is high risk for patient's life to complete the operation, we will stop that. We will further transfer the patient for oncology, for radiotherapy treatment or adjuvant treatment. There is a predictive factor for pediatric craniofaryngoma for recurrence, which included the younger age, male sex, and morphological feature that's very operative to increases for recurrence, which includes a right size tumor location and tumor adherent to the surrounding tissue. And clinical presentation, there is increased risk of hydrocephalus or visual disturbance, hormonal-related symptoms. Also, there is a molecular feature with Ki67 expression of B53 gene, also have risk for recurrence. From our experience, we will discuss. I have two cases for giant craniofaryngomas, which was seen in our institute during the few years in our country. First case is about 7 years old patient with no non-medical illnesses, presented with a moderate intensity headache, frequent vomiting, and visual disturbance, no seizure or loss of conscious neurological examination. You have underweight child, conscious visual examination, hand movement bilaterally with anesthetic babylon edema and fundoscope. And radiological investigation, brain MRI show a cellular supracellular mass lesion with posterior extension to the right. Here we see a brain axial T1 and T with contrast and non-contrast, which show the solid enhanced lesion with the cystic part extended to the cerebropontine angle in the right side. This is the coronal and sagittal view, also showing the lesion and the cystic part extending to posterior fossa and the CV angle. This is a T2 view image, axial and sagittal view. Show the solid parts. This is the solid part, and this is the cystic part in the CV angle. This is the flare image. This is the cystic part, compressing the brainstem, cerebellum. Second case is a 9-year-old male with no known medical illnesses, presented with frequent vomiting, total loss of vision, no seizure or loss of consciousness, neurological examination, show only visual, no light perception in both eyes. This is the axial T1, contrast and non-contrast, show the solid mass lesion. The cystic part, this is the enhanced lesion. The cystic part, this is huge cystic part compressing the right lateral ventricle. This is the sagittal view, show the cystic part extending from the base up to the top of the cranium. So this is a coronal enhanced T1, show the solid mass and the cystic part of the region. The flare show the cystic mass. The diffusion weighted image. Full-lab examination, the hormone result was normal for the first case, and the second case have adenocorticotropic deficiency. Management plan was the total excision for maximum excision for the stellar and posterior fossa cyst for all cases. Active for complete routine investigation and pediatric anesthesia fitness taken. Supine fixed in supine field frame. Cranial approach for was used in both cases. Microscopic assisted surgery. This is the cystic part of the tumor was excised. And so this is the cystic part of the tumor outside the operating craniotomy. This is the cystic part and the solid part. The cavity of the signal of the tumor. The frontal cerebral veins. This is a photograph for the tumor exists from the both operations. Complication. For the first case, we have both diabetic insipidus in both cases with hypernatremia. This was controlled in ICU by pediatric and endocrinologist and desmopressin nasal spray. For the second case, also we have central hypoadrenalism, which was controlled in ICU and by pediatric endocrinologist. Post-operative outcome. This is for the first case with the posterior fossa extension. We see a total excision of the solid and the cystic part. The patient improved good and discharged with desmopressin medication. We did the clinical follow-up with visual improvement of visual disturbance. For the second case, subtotal resection was done. We see this solid part calcification was not removed. It was difficult to remove, and we are afraid of adhesion to the surrounding important structure, blood vessels and the thalamus and hypothalamus. So we decided to stop the operation and to follow the patient clinically and to go for radiotherapy, but the parents refused to radiation therapy. For follow-up, for both cases, we are following for 2 years. There is normal vision in the first case, no tumor recurrence. Desmopressin stopped 3 months after the discharge. The second case still have no visual improvement, no tumor recurrence, but still there is a remnant. There is obesity, steroid and desmopressin medication was to the time of follow-up still used by the patient. And the tumor was in situ not increased and not changing in size. Summary for a giant craniotomy are rare, and these cases highlighted the importance of timely and effective surgical intervention in managing such cases. Multidisciplinary team, medical, pediatric, endocrine, oncology, and neurosurgery, anesthesia, and neurointensive should be dealt with these cases. Craniotomy should be operated in a well-equipped center with an experience in craniotomy cases. Through operative planning, the cranial approach, and its modification can be dealt with most of these cases. Thank you.
Hey, Ahmed.
Thank you, Dr. Adnan, for this amazing lecture. Again, I'm so appreciated for accepting my invitation to have this webinar with Professor Sabeh. Well, if there is an inquiry or question, they can ask.
Yeah, I think there's one in the chat box, Ahmed. Do you
Okay,
see it?
Just a minute.
Oh, I'm sorry, that's from Dr. Sabea.
Yeah.
Okay, let's see, do you see any new ones?
Well, if you permit me, I'm gonna just share my screen.
Okay.
Just a minute. Well, here we'll have a lecture with Professor Luis Borba about the tumors of the cranial cervical junctions, and also with Professor Zailili
Oh, okay.
occipital cervical
Very
fixations.
good. In 2 weeks. 2 weeks.
Yeah.
Very good. It's a good
Uh,
night.
yeah. Okay, thank you.
Okay, very good. Thanks everyone for participating, Dr. Subeda and Dr. Alawadi especially, and thanks for putting together everything, Ahmed. You know, we're going to try to expand the Walter Dandy network because, as I said to Dr. Subeda, we need new blood that wants to come into the system of the neurosurgery community of global education, and we will welcome them. But stay tuned.
Yeah. Yeah,
Thanks,
as I told
everybody. Go ahead,
okay.
Ahmed.
Well, I just talked with Professor Salim about this topic last week, and as I told you that we will announce for this type of society in the coming few days, inshallah. As I told you, we'll have subtypes for residents and subtype for neurosurgeons. So that will be revealed and explained in the few weeks, inshallah.
Okay, stay tuned for the news. Good night, everybody.
Bye. Thank you very much indeed.
Well, thank you, John. Thank you,
Thank
Professor.
you. See you, Doctor.
Thank you, Dr. Adnan.
Stopped.